Wonderful. That looks like everyone is through. So welcome everybody to this webinar. My name's Emma, and I'm from the team here at Medic Mind and Study Mind. So in this webinar today, as I know you've all signed up for, we're going to be talking through mastering the MMI for going into medical school. So just to let everybody know, the chat is going to be open throughout the whole of this webinar. So if you have any questions, feel free to use it throughout it. There's also a question and answer session at the end. So if you want to wait until then, that's absolutely fine as well. If you don't want to ask the question openly on the chat, feel free to direct message on it as well, and I'll be able to pick that up for you. But yeah, just before we fully get started, we're delighted today that this webinar is sponsored by the brand new University of Hertfordshire Medical School. So the University of Hertfordshire Medical School is opening in 2026 for a brand new cohort of international students. They're a brilliant medical school based just outside of London. And if you want to find more information about that, we will send some more information in the email at the end as well. So just to let everybody know, you will get an email after this, which will have the recording in, and you'll be able to ask any further questions there as well. So I'm going to stop talking and I'm going to hand over to our expert.
Hiya. So welcome everyone. My name is Hamza. I am a final year medical student at the University of Glasgow, and I'm here to take the second part of mastering the MMI. I did the session kind of a couple of weeks ago where we looked into work experience and skills questions. Today we're going to look a little bit into medical ethics. We're going to talk about key principles for medical ethics. We're also then going to have a very quick, brief talk through of data interpretation, role play, communication skills questions that are going to be slightly different, kind of other common MMI circuit questions that you might have in your exam. So we're going to focus a little bit to start with on medical ethics, and then we're going to talk a little bit about kind of other questions and maybe a little bit at the end about how to generally approach any MMI station that you might have. So ethics questions, which are going to make up the most of today's session, are really, really common in the MMI. So you're going to be given a scenario usually and asked to make some sort of judgment or decision based on the information given to you. To approach ethics questions, the main pieces of information you need to be aware of are the 4 pillars of medical ethics. So the 4 pillars of medical ethics are autonomy, which is the right of the patient to make their own choices around their treatment, obviously in line with what is kind of treatment options. Beneficence, the aim of all medicine in general is to do good and benefit. That is usually kind of weighed up against non-maleficence, which is the principle that first we should do no harm. Now, these two principles kind of go a little bit hand in hand because beneficence and non-maleficence are kind of competing ideas in a way, where beneficence we aim to do overall good and non-maleficence we want to do as minimal harm as possible. But the idea is balancing those two up and weighing up the benefits and the risks of any potential treatment because everything we do, 99% of medicine, there are some side effects, there are some risks with our healthcare decisions that we'll make. But the idea is to overall do good to patients as much as possible. And then justice, which is that medical treatment should be fair and it should be equitable. And we shouldn't base our medical decisions based on wealth or social status, but instead base our decisions on clinical need. So patients who need the healthcare first are more entitled to that healthcare if they're more emergent. 2 principles you need to be kind of aware of as well is capacity and consent and competence. So the legal age in the UK for consent is 16. Before the age of 16, a patient can be deemed competent to make decisions regarding their care if they fall under the Fraser Guidelines. The Fraser Guidelines assesses something called Gillick competence, and Gillick competence initially is specific to, or initially was specific to patients who were requesting the oral contraceptive pill. So the story around the Fraser Guidelines was a 13-year-old girl, sorry, she was 14, I think, at the time. She had just turned 14. 14-year-old girl went to her GP and asked for contraception. She was sexually active with her, also under the age of 16 boyfriend at the time, and she was worried about the risk of pregnancy, and she asked for oral contraception. The GP at the time determined that she was probably at risk of continuing to have continuing to have unprotected sex if she wasn't given the oral contraception first. The GP at the time also said that she was deemed competent. She had a good understanding of the risks of continuing to undertake unprotected sexual intercourse without the pill, and she had a good understanding of the risks and benefits of the pill. So the GP kind of went, in a normal situation, if the patient was over the age of 16, they would have been deemed to have capacity at the time. So capacity being a functional term, meaning that you're able to consent to any form of treatment. To have capacity, basically, you need to be able to take in information, retain that information, process the risks and benefits that are given to you, and come to a conclusion that you can then communicate. So, kind of the big things, you need to be able to take something in, you need to be able to retain and remember your decision, you need to be able to process the risks and benefits, and you need to be able to communicate your decision. Those are the big parts of the capacity. And the GP at the time said, um, the child had capacity based under the old capacity laws. Her mother was really annoyed at this and sued the GP, and it went all the way up to the House of Lords, where Lord Fraser, hence the Fraser Guidelines, ruled in favor of the GP and said, actually, overall, the GP's decision was in the best interest of the patient at the time, and actually would have been it was beneficial to the patient, and therefore kind of establish these new guidelines which determine Gillick competence, which is competence under the age of 16. But being able to think about those things are really important, and considering capacity under the age of 16 is a common thing that they'll ask you about in MMI interviews. And having knowledge of that is quite a good thing to be aware of. Okay. The other kind of principle you want to be aware of is confidentiality. So confidentiality, just next slide. Oh, so these are the factors that determine if someone is Gillick competent. So Gillick competent, first and most important factor is understanding. So they need to be able to understand the advice and the implications of having treatment. Um, the goal is first and foremost to persuade the child to inform the parents or allow a healthcare professional to inform parents. So if they're able to do that, then obviously Gillick competence doesn't even kind of click in there. The fact that they're likely to continue sexual intercourse without the treatment, or likely to continue or come to harm. So in general, the big factor here is physical or mental harm. Mental health are likely to suffer unless any form of treatment is received, and then therefore it is the best interest to receive treatment or advice. Those are the factors that determine if someone is Gillick competent. Confidentiality is another really important thing that comes up a lot in medicine. So confidentiality is also right. It allows the benefits of confidentiality. Basically, healthcare is a really privileged position, and us as healthcare professionals and healthcare providers, we get a lot of sensitive information from our patients, and confidentiality helps us, helps patients trust us essentially, which is the most important thing. It creates a trust between us and the patient, which means that we can treat the patients in the best way possible. However, and what's really important to recognize is that confidentiality is not absolute. So your right to confidentiality doesn't always exist. There are three factors in which confidentiality can be broken. First and foremost, if the patient is deemed as at risk to themselves, that at that point, confidentiality can be broken. Secondly, if the patient is at risk to someone else, so if a patient is at risk to other people. The best kind of examples of these are patients who are HIV or STI positive, who won't be informing their partner or don't want to inform their partner that they're STI positive. At that point, confidentiality can be broken because you also have a duty of care to the partner to make sure that they are safe. At the third main category is the patient is deemed a risk to society in general. Now, this is really tough to gauge, but the best example you'll know in medicine will be, or the most common example you'll be aware of in medicine, um, is patients who are um, patients who may maybe have a reason why they shouldn't be driving, i.e., potentially they have epilepsy and are currently seizure active. They might have a diabetic eye problem, or they might have lost their vision, so they shouldn't be driving. The doctors have a duty of care, and they can inform the DVLA in order to make sure that their driving licenses are taken away if patients are kind of driving without being fit or healthy. Cool. So those are the most important parts to medical ethics. So let's talk about, oh, we've got some questions. Does Gillick competency only apply to under 16s to receive birth control, or can it apply to other um, situations as well? It can apply to pretty much everything. So an under 16 can consent to other treatment if, again, they deem to have an understanding and they deem to have capacity. Actually, the Gillick competence criteria for other things is a lot less stringent than it is for contraception. For contraception, the Gillick competence criteria is quite stringent. For other things, if they're deemed to have normal levels of capacity, then they are entitled to make decisions, especially if it's in life-saving care. They couldn't refuse treatment though. So actually, there's a unique difference between England and Scotland on the laws of this. But essentially, at 16, you gain capacity in England to refuse and accept treatment. In Scotland, and under 16, you can't refuse treatment. In Scotland, it's the same. Under 16, you can't refuse treatment. Between 16 and 18, however, you can, in pretty much all circumstances, accept treatment, but you can't refuse treatment. And then over 18, you get the right to refuse treatment. Okay, hello. As a Scottish applicant trying to apply to Scottish universities, is it handy to know about the UA NHS trust and system in other parts of the UK, or current topics in other parts of the UK, or just Scotland? If you're only applying to Scottish universities, they'll generally only ever ask you about Scottish things, so they won't ask you about NHS structure outside of Scotland in general. Does talking to another doctor about a case for their input still count as breaking confidentiality? Depends on how you do it. So if you give patient identifying information, then yes, it would be breaking confidentiality. If the patient can be identified from the story that you give, then yes, you can break confidentiality. However, if the doctor is also involved in the patient's care, maybe not. If the doctor isn't involved in the patient's care and you give patient identifying information, it probably does break confidentiality. If you do it anonymized, so a lot of cases, patients will be used for teaching purposes, but in an anonymized setting, i.e., Mr. X is an 8-year-old man who comes in with X, Y, and Z symptom, and you keep it kind of anonymized. You don't have any patient identifying information, then you should be fine. If the partner of your patient with HIV is not under your care, do you still have a duty of care, and you still have to tell the partner? Yes. So you have a duty of care that is beyond just your patients, in inverted commas. But yes, you still do have a duty of care. Hi, do these ethical pillars apply to veterinary medicine in the same way? I don't think so. I guess. I guess you'd be less. There wouldn't be autonomy in vets. I don't think that, and I don't think there'd be a capacity issue in a veterinary medicine setting because, I mean, I don't think animals can communicate their decisions, so I don't think they would ever be deemed to have capacity to make decisions. I guess you have duty of care also to the owners, which is different. You probably do have beneficence and non-maleficence, but I think the veterinary standards would be slightly different, and the expectations in ethical situations for vets would be slightly different. I don't think they would apply in the same way. Unfortunately, I couldn't tell you because I'm not a vet, so I'm not a vet med, so I wouldn't be able to kind of help, like tell you exactly where the differences lie, but I don't expect them to be the same.
Hamza, I've just had another quick question as a direct message, if I could just do that one quickly.
Yeah, of course.
So this person said HIV medication can make the viral load really low. And
Yeah.
I heard someone said this means it isn't classified with other communicable diseases, e.g. measles, and thus you can't inform a patient's partner without their consent, even if they are not going to. Is this true?
That would be correct. Yeah. So if it's well-controlled HIV, with in general, we look at something called CD4 cell count. So a CD4 cell count of over 200 and a viral load of less than, I think it's about 100 cells per deciliter. It's very low. It means that HIV isn't transmissible, which means actually it's non-communicable at all. In general, this applies to patients who might not be on treatment, or when I talk about HIV as an example, I'm generally talking about patients who aren't on treatment yet, or patients who are still continuing to have unprotected sex with their partner. It's a very different situation. It's very specific. But yes, you would be correct in that saying that if your viral cell count is very low and you're not transmissible, it would be unethical to inform because there isn't a risk. So if we go back to those three principles and we consider that there has to be a credible risk to someone else in order for confidentiality to be broken. And in that case, you couldn't say that there was a credible risk because you know that that patient can't transmit the HIV. So, yeah, no, you would be correct in saying that. How does confidentiality apply to genetically communicable diseases such as Huntington's? This is a very good question. So in general, you could, so if a father gets diagnosed with Huntington's, there is the ability, so you can, in theory, break confidentiality to tell the children who might be at high risk of developing Huntington's disease. You couldn't tell the partner. So, if, for example, if someone is a high risk of or has developed Huntington's disease and then doesn't tell their wife before they have children, you couldn't break confidentiality in that case and tell the partner that this person has Huntington's and that your kids might be at risk of having Huntington's if the kids aren't already there or already high risk. So it's a really interesting difference, and there is a really important difference there. If the it's again all about risk. So if if there is evidence that a parent has Huntington's, and then there is a risk to the children, then yes, you can break confidentiality in that situation and inform the children that they are at risk of Huntington's disease. You couldn't tell them that your partner or your father has Huntington's, but you could say that based on the information we have currently, you're at risk of Huntington's, and we recommend getting genetic testing and counseling. That's what you could do. Remember, even when we're breaking confidentiality, we're doing it in a way that is as minimally informative or as minimally kind of damaging to the individual patient. So we're trying to do it in a way that still retains the trust. So in that setting, you probably wouldn't tell them your dad has Huntington's, but yeah, you probably would say, oh, like you are at risk of Huntington's. Please go and get genetic counseling or genetic testing. Does that make sense? Tough question though, but good question. Any other ethical questions that people might have before we have a go at this? So, what are people's thoughts on this question? In this scenario, what do you want to know and what do you want to do in an interview? What things would you consider that are really important to consider? Do we have the right to ask the age of her partner? Yeah, you do. Yeah. So safeguarding is really, really important, especially in a 13-year-old girl. So what would concern you in that situation? When we talk about age of the partner, what would be concerning for you? Yeah, speak to the girl if she understands the side effects of oral contraception. I'll buy that. Yeah. Capacity, I would buy that, so that's quite important. If she's Gillick competent, yeah. So the factors we want to know is would she be willing to tell her parents? Is she at risk of continuing worsening mental or physical harm if she didn't get the contraception? And is she likely to continue having sex without if she wasn't given the oral contraceptive pill? Um, since the patient is under 30, is 13 years old, I want to know if she isn't forced in any way to have sex. Yeah, I would agree with that. Um, I would, I would buy that. Yeah, I think you want to know. Um, you want to know you want to know that there isn't any coercion or any kind of forcefulness, if there's any positions of authority. Okay, let's play a bit of devil's advocate here. So we've talked a lot about this so far. How old is the patient? How old is the boyfriend? How long is the relationship? Um, is she taking substances? Yeah, I like that. But let's play devil's advocate here. Um, the so the boyfriend is 20 and is this patient's athletics coach. Who do you want to tell? A little bit of ethical devil's advocate or trying to extend here. Would you tell the parents or are you going to not? Yeah. So in general, the way this happens is in hospitals, we have children safeguarding leads who are doctors, usually pediatricians. This is probably in GP. So in GP land, it's probably slightly different, but you probably would talk to the police here. Um, like this is it's in GP practice, it's likely between 9 and 5. So you probably would go straight to the police here. And you probably would you let the girl go? So would you let her go home? Would you force her to stay? Would you ask what would you do? Get contact info, stay, encourage her to stay? Yeah. So I probably wouldn't let her go in this situation. In the situation that the boyfriend is 20 and and her athletics coach. Remember, she's at direct risk of harm if she goes home and she says, "Oh, well, the police are now onto us." There's a potential that something might go wrong, which means for her safety, probably better to encourage her to stay. Um, you probably can't hold her. No, that's true because you can't detain her. There's no evidence of anything that's detainable here. But at the same time, you probably would encourage her to stay. You'd probably be quite discreet about it. Um, some people have said parents here. Um, I probably wouldn't tell her parents. I don't think so. So this is really important about who to inform. Is it really important that you talk about you talk to her parents? No. Are the parents going to be able to do anything? No. So you probably don't have any real need to tell her parents in this situation. Um, if she does leave, what would you do? That's a good question. You wouldn't do anything. You would inform the police and then you'd let the police do anything. You're a doctor, you're not a vigilante, so you don't have any real power to really go out and like force her to do anything. You would hope the police would be at her door like in an hour and then do a thorough investigation. Your job is to find out what's going on and inform the relevant authorities, so you wouldn't do anything. How do you go about informing her that her confidentiality is going to be breached? You say you have to be honest at the beginning of the conversation. So you say everything that you say here is confidential unless I am concerned about your safety or I'm concerned about the safety of someone else. And that's how you would open a consultation anyway. But secondly, when you now start realizing that this is concerning, you ask about open questions. You say, and how does that make you feel? Do you feel safe at the moment? And if she says yes, then you might say something along the lines of, well, for me, as the doctor, I'm quite concerned about some of the things that you've told me. I think it would be appropriate for me to go and ask for some senior help or to contact the relevant authorities. Now, I appreciate that that might not be what you are kind of looking for at the moment, but at the same time, I think there's an importance here that we recognize that this is unsafe. Remember, Jemima's 13. She probably has an understanding that what she's doing is not exactly what her friends would be doing in that same situation, or her relationship with a 20-year-old isn't the same as what her friends might be in. So she probably has a little bit of an understanding there in this situation, where that something isn't quite exactly right. Even if her and her boyfriend are getting along very well, I think it's important to recognize that Jemima probably does have a good enough understanding that, things aren't exactly the way they are for her friends. In what ways would you contact the police? So there's a number. I think I don't think it's 111. I think it's like 119 or something. And it's like an out of hours police telephone. It's not a 999 call because it's not an emergency. But it's a confidential helpline that goes around the back and the police will take to tackle her. Can you give her details to police if she leaves? Yeah, you can. Yeah, so whatever information you can get, you can inform um the police. This is a really good question, Halima. From what age would the relationship be considered concerning? All sexual relationships under the age of 13 are safeguarding issues automatically. So even if it's a 12-year-old with a 15-year-old or a 12-year-old and a 12-year-old, that is automatically concerning as a safeguarding issue. There's nuance to that, but that's not your concern to worry about. The guidelines are pretty clear on that. Anyone under the age of 13 who is having sexual intercourse is an automatic cause for concern. Then you would think about the position. So 13 with 16, maybe if they're in the same school, might not be as concerning, even though under the law, that is a problem. But again, might not be as concerning to you. But if there is a 13 and over 18, I would definitely be very concerned about that. Maybe 13 and if there's any position of authority or any kind of potential for grooming or anything like that, you would automatically be concerned. Would you have to tell her that you were going to tell the police? Yeah, generally you would. Yeah, you would have to inform her that you are going to, and in any breaches of confidentiality, you would have to inform the patient that you are going to breach the confidentiality. Um, are you allowed to ask for the boyfriend's identity? You could, but the patient doesn't have to give it to you. But you could say, okay, how did you meet your boyfriend? You might not do it as openly as what is your boyfriend's name and address, because the patient's definitely not going to give you that information. But you might ask you, how did you meet your boyfriend? And then the patient might open up the lead coach of the athletics team or whatever the relationship is. Or we met at school or something like that. And then you might that's all consultation skill stuff. Like you're not gonna be direct, but you're gonna find ways of detecting that information without being direct. And she doesn't need to disclose her boyfriend's age either. Um, she doesn't need to, there's no like legal requirement for her to do that. You would just express concern when there is kind of something going on. You might ask, how old is your boyfriend? And she might say, I don't want to tell you. And then and then you might make a judgment call based on that. What happens if it happens that you know the boyfriend or partner? Would you have to get someone else to treat her? That's a really good question. I don't know. I don't think so. I would hazard a guess that you probably wouldn't have to get someone else to treat her. You have a duty of care to her and the partner. You'd have to keep them separate. Remember, you're a professional. I would hazard a guess you don't have to. If you feel uncomfortable, maybe you can, but I don't think you do have to. But that is a really good question. Under what circumstances would you refuse to give her the contraceptive? You know, if she doesn't show a clear understanding of the risks of the contraceptive, if she says something like, I'm not going to continue having sex if I don't get the contraceptives, then that's pretty much your problem solved a little bit. You don't have to give her the contraceptive because you would go, oh well, I don't think that would be appropriate. Um, if she's like, oh, I'll come back to my parents and they can have a chat with you later, that's better for you. Basically, if she doesn't meet any of the requirements of the Fraser guidelines, then you don't want to give her the contraceptive. At the same time, I've never seen it in practice where a doctor will refuse now. Not because of anything particular, but even even in some semi-concerning situations, the risk of harm to the patient is much greater than the risk of um like if the patient becomes pregnant or something happens, the risk of mental or physical harm to that patient is much higher. So I would consider, and I think it's really important, um you consider the safeguarding issue separately to the contraceptive issue. The contraceptive issue is exclusively Fraser guidelines related. The safeguarding issue is a really important separate issue. So even if the boyfriend is over the age of 18 and maybe in a position of authority, that doesn't affect necessarily your decision to give the contraceptive. You would deal with the safeguarding issue internally. But if the patient is saying that I'm going to continue having sexual intercourse without the contraceptive, then your priority is protecting the mental and physical well-being of your patient. And so you probably still give the contraceptive. Um, do you need to do anything to protect yourself legally? I mean, every doctor needs to protect themselves legally. We're all part of, even medical students, you're all part of a union. And then you would contact your MDU rep or BPS rep or whatever. Um, if you were observing a GP as a medical student, the safeguarding issue appears that the GP does nothing about. Do you have a requirement to inform authorities? Yes, because safeguarding is everyone's job. But also you probably wouldn't do it directly. What you would do is you would express your concern to your GP supervisor and you would say, "Hi, did that scenario not concern you?" And then the GP will say, "Yeah, it did. I'm going to inform the authorities." Or, "No, it didn't. These are my reasons why it didn't concern me." And then you can have a conversation with your GP. Remember, we've still got a chain of command. We still want to go via the relevant people. You can express your concerns to your GP. If the GP still continues to do nothing about it, contact the MDU and see what your responsibilities are, because that then becomes different. Can a 13-year-old ask for an abortion under Fraser guidelines or within the 24-week time frame? Yes, they can. And I've seen it happen in A&E once, where a child under the age of 18 or under the age of 16 had come in for an abortion and the doctors chose to give it. Because again, the risk of mental or physical harm was so much greater. And so it was in the child's best interest to get the abortion at that point. Would you handle it any differently if the patient is in care? No. You would talk to the same people, you talk to your local safeguarding lead, and you would inform the relevant authorities in the same way. I don't think you approach it any differently.
I just had another direct question as well, if that's
Yeah.
okay. So I think you've sort of covered this, but this person said, in these situations, can you prescribe the contraceptives to her without informing the parents or just give her the information?
Um, you can prescribe the contraceptive if it's still in the child's best interest to get the contraceptive. The safeguarding issue is separate to the contraceptive issue. So that's kind of the general gist of it. And understanding that yes, you want to explore the safeguarding issue because that's probably primary issue at the moment in your consult, but your safeguarding issue is separate to your contraceptive issue. And so if they meet the Fraser guidelines requirements, then they probably can still be given, or they definitely can still be given the contraceptive. All right, that's okay. One final question. Can you still contact the authorities if the patient implies but doesn't confirm the age of their partner to be over 18? Thanks. That is a very good question. You can contact your local child safeguarding lead who will take more information. If the patient implies something that concerns you, you go to the relevant authorities to express your concern. That's the simple gist of the rule. Anything that's concerning you, even if the patient doesn't say anything, but when you're examining the patient, you see bruising, you're thinking, but the patient goes, "Oh, no, no, it's fine. Don't worry about it." If it's something that's concerning you, that a safeguarding issue is in play here, you contact the relevant safeguarding lead and safeguarding authorities and social work, and then the police. Um, in that bruising situation, you probably send the child to A&E. The A&E will then take a lot of that. But then you probably in your referral will say something like concern of non-accidental injury here. But at the same time, if you have justified and legitimate concern for a patient, then safeguarding always comes first. And that's kind of it. Your safeguarding brain ticks in and you would inform the relevant authorities. Because again, informing the authorities doesn't mean anything inherently. Like it's not that that person, the boyfriend is automatically arrested and charged. The police then explore that. But if you've got a concern, and you don't inform the authorities, and then the patient goes on to further harm, that's on you as the doctor because you've recognized that there was an issue or a concern, and then you didn't do anything about it. So that legally, that liability then falls to you. You inform the police. It turns out that the boyfriend's 15, they met at school. The police aren't going to charge them. The police don't charge them. That's an issue separately or an issue resolved. Um, but you are better off from your own personal liability and from the patient safety perspective, informing if there is legitimate concern. That's kind of it. That's the general gist of the rule. Right, that's the last question about ethics. But um, when you're preparing for an ethics question, not all ethics questions are going to be scenarios. You might just be asked your perspective on a complex ethical topic, i.e., abortion or euthanasia or something like that. Um, think both sides of the answer and come to a conclusion. Consider both in all perspectives, even if you have a strong opinion. You want to show critical thinking. You want to show that you're able to appraise the information that's presented to you. Using the four pillars as the key basis to your answer. And then don't sit on the fence. Lots of students make that mistake because they end up sitting on the fence and they're not giving a conclusion. Don't sit on the fence, come to a justified conclusion. And that would be how you approach an ethical scenario.
Great, thank you. So just before we move on, I just wanted to inform everyone a little bit of the other interview support that we have available here at MedicMind. Obviously, we run these free webinars, and I know some people have been asking in the chat for the previous webinar recording. I'll make sure that that's put in the chat before the end of this so you can access that as well. If you miss it, it is actually on the MedicMind YouTube at the same time. And the MedicMind YouTube is a really good place to get a load of free resources, which has all of these old webinars on there as well. And you'll be able to rewatch over them in preparation for your MMIs and your panel interviews as well. So I just wanted to let you know a little bit more about some of the other support that we have on in case you're interested. So we do offer bespoke one-to-one tutoring. All of our tutors are experts. They tend to be previous students or doctors who have been through it themselves and understand how the interview process works and moving forward. We also have our MMI live days. These are really, really good if you want some in-person or online practice doing the different stations, understanding how the questions might be asked of you and everything like that. You can get these in sort of a package or you can do a one-on-one. If you want to do a full-on sort of like mock interview prior to you actually doing your MMI, these are really useful things. We also have a really good online course. This is really good if you're looking for something a bit more flexible, a bit more self-paced. You can go through it as you want. You can rewatch any videos that come up. They're full of videos, they're full of revision cards, they're full of everything that you might need. And it also has all of the practice stations as well. We also have a whole range of ebooks available. These cover anything from how to answer medical ethics questions, which obviously you've all just been through, but then also all the different stations and everything else that might come up in your MMI or your panel interviews as well. So all of these after this webinar, I'm going to send you all of this information so you've got it all, and you can contact us and contact our interview support team, and they'll be able to help you figure out if there is anything that we can help you with as well. So now we will move back on. So Hamza, I'll pass back over to you.
Perfect. So the last couple of questions we'll have a bit of a chat about before I answer any bit more of an open Q&A are hot topics, data interpretation, and role play. We're just going to touch on each of them in one slide, essentially. So not anything particularly kind of too much depth on them, but we'll have a chat about how to approach them. So hot topics. Generally, two ways about it. These questions are either going to present you with some sort of article or some sort of information and ask you something about that, or they're going to ask you about just something general that you've read recently. They don't expect you to know everything, so be honest if you haven't read about a specific question that they ask. The important thing to be doing is doing wider reading in preparation for your exams or your interviews. And what I would do is I would look at BBC Health, so bbc.com or BBC News, bbc.co.uk/news/health is a really good website for all of the things that are going on in health. This year, I would expect if you were going to be asked questions, you'd be asked questions about doctor strikes, especially because of the ones that are going on currently, hospital waiting times, I would be expecting you to be asked about the bottleneck and the backlog. So specialty training bottlenecks and waiting time backlog. Those are probably the big current affairs topics in healthcare or in British healthcare or in NHS structure. So all of those um, I would expect to be part of that. Um, and then link to what you would do in any situation. So if you've read, basically go on and talk about any further research you would do, how you would get in access to further information, or if it's an article that you've read, talk about the process and what you've done to improve on your knowledge after that on a particular topic. So kind of talk about part of that process and talk about um, show critical thinking and critical engagement with any text that you've had. Also, they might present you with data or data interpretation and hot topics. They might present you with articles that have got weaknesses in them. Don't just assume that because they've given you information that it's always going to be strengths. Talk about some of the weaknesses that are going on in part of that information. Does that make sense? Cool. Next.
There was a couple of questions in the chat. I don't know if you want to do those later though.
Yeah, I'll do them now.
Okay, cool. There's just how do you answer a hot topic question? Do you need to provide a balanced argument and conclusion?
Again, it's very question dependent. If you're asked about article you've read, you can just introduce the article, talk about what you learned from it, talk about the strengths and weaknesses of the article, and talk about how you'd go on to get further information. If you are presented with a debate article or a debate hot topic article, and that you have to then interpret, I would do strengths and I introduce again, start with an introduction. What is the article saying? Just rephrase what they're saying, then do strengths and weaknesses, and then come to a conclusion on your personal perspective. What do you mean by further research you've gone on to do? So essentially, if you've read an article about heart disease, how have you gone on to learn more about heart disease? Have you watched videos about heart disease, or have you like gone and spoken to a patient at work experience about heart disease, or have you done a presentation on heart disease for your local med school, like your med soc, at your school? Whatever, because reading an article is the bare minimum expectation that medical schools are going to have, that you've read some articles. What they want to see is that you've taken an article or you've taken data from that you've been given and you've gone on and you've done something with it. So you've gone on and created, or you've gone on and synthesized that article into a presentation, or you've gone on and done further research or further reading about the topic of that article, or you've gone on to do something else with it. Whatever you've done, whatever article or whatever text you're reading, don't just leave it at the text because there's no point in that. Show that you've developed understanding and you've developed curiosity and critical engagement with that. So that's kind of what they're looking for. Okay, so data interpretation, you'll be given some sort of data. You're either going to be asked to kind of appraise the data. So you might be given a graph or a table, and you'll be asked to identify strengths and weaknesses. Being critical there is really important. And then you might be asked to do a calculation. Either way, talking out loud is really, really important. So here, if you were given a calculation to do, even as you were processing the data or the calculation, say the things that you're thinking about or the things that you're reading. So if you're like looking at a table or a graph, you might say, okay, so the first thing I notice is the general trend in blood sugar. It goes up as time goes up. That probably implies something, or whatever the graph that you're given is going to imply, because what that will allow you to the examiner to do is to jump in and say, okay, maybe you're not going in the right direction. Have you considered this part of the calculation, or have you taken into account this part of the data? So the examiner can then jump in and support you if you're going on the wrong direction. But talking out loud is really, really important. And then being critical, as I mentioned earlier, you might have weaknesses in the data that you're given. So think about the experimental methods and evaluate what's being given. I mean, it's the same as like an A-level biology or an A-level chemistry question where you're asked to interpret and evaluate research methods. You're approaching it from the same way. Okay, do these results and these conclusions make sense from the information that you've been given or from the data that you've been given? Someone's asked, does it have to be a research article that led me to do further research? Can it be from attending virtual uni lectures and tutorials? Yeah, that's completely fine. Attending a uni tutorial or a lecture could be the beginning point, but then maybe you read something, or maybe you went to another lecture, or maybe you did something else after that. And again, you can show the process still from one of those parts. Is it bad if you can't do the drug calculations or get it wrong? Not inherently. Um, if you're getting it wrong, but you're not talking out loud to the examiner to show them your thought process, probably not a great way to do it. The answer isn't the most important thing. Showing you've got a logical process to your approach is probably more important. There's nothing wrong with getting it wrong, but allow the examiner to jump in if you're going in the wrong direction. That's fine. Where can you find examples of these kind of questions? There's loads on the Medic Mind UCAT like courses and the online courses, a load of these types of questions, lots of the graphs and stuff. But actually, the other way you can find them is in your A-level chemistry and biology papers, because you do a lot of these data interpretation questions all of the time. They're no different to some of the calculations you'll be expected to do as part of your A-level biology or chemistry. If you've talked about a specific treatment in your PS, would it be good to assume those article style questions may be based on that? Not inherently. Most universities don't read your personal statement before your interview at all. And actually 90% of them won't. So um I would read around that though, because you've already shown an interest in that in your personal statement. So why not use that as your article? You only have to read one or two articles. You don't have to read a crazy amount of stuff. But if you've talked about something specific in there, you've already shown some sort of process or some sort of logic. Talk about that. I don't think that would necessarily be a wrong thing to do. But again, they won't ask you specific questions based on something. There might be some stations that are personal statement stations, but even then, they won't be data interpretation marking points. They'll only ask you about general things about your PPS. Very rare though now. No one really reads a PS anymore. No, honestly. Like, you said we would only need to read one or two articles, but wouldn't this limit our knowledge to in-depth about a few things? Yeah, but again, this is going to be one station. It's not going to be an 8-station MMI that's entirely data interpretation. It's okay to have a really in-depth knowledge about something small right now. Again, breadth, not depth, probably when you get into medical school, but when you're currently looking at prepping for an interview, you want to maximize your time as much as possible, go into depth on one topic because that shows interest in a particular area. Reading a load of things about lots of topics doesn't really show interest in a specific area, which is kind of what these stations aren't designed to test your knowledge. They're not designed to test your suitability for medical school from a knowledge standpoint. They're designed to test your suitability from an interest standpoint. They're designed to see that if you go to medical school where you're an independent learner, um, because when you're an independent learner, they want to see whether you'd be able to process and and go into depth. They want to be able to see that, let's say you've had an interesting lecture about something in medical school, that you would then be able to go off and find your own research and find the right resources and then appraise those resources. They want to see those skills. But so just as a follow-up, you said, shouldn't we have some breadth because we don't know what they'll ask? They're never going to ask you something specific about a particular topic unless they provide the information for you specifically in that question. There are two types of hot topic questions. They'll either give you the data, which is more data interpretation actually. They'll either give you the article that they want you to read and they want you to praise, or they'll ask you, tell me something that you've read recently in the news that's going on in healthcare. And then you would just be asked to find one topic that you've read an article about. That's it. They're not going to ask you, tell me how cells work, or tell me how protein synthesis in rats shows. Um, they're not going to ask you something that specific because they don't need to do that. They want to see your critical appraisal station, critical appraisal kind of they want to show you critical appraisal. Should you go in depth on a hot topic or a specific? Yeah, I would go in depth on a hot topic. Um, I would do both. So I would read a little bit about, I would go in depth on both a hot topic, probably doctor strikes this year, and then also show a little bit of breadth and a little bit of depth on something you're interested in. So maybe you gave a presentation on heart disease or something that you found really interesting uh, during your research. I would do both. Um, any tips on answering these questions in a pre-recorded online MMI? Well, perhaps there won't be any interventional back and forth. Oh, that sounds brutal. I did my interview 6 years ago, so unfortunately everything was in person at the time. That sounds really tough. I would hope that if you get an online MMI, there'd at least be someone there in front of you who might be talking at you. I don't want to put a limb out there. I don't know many medical schools that are doing pre-recorded online MMIs. That sounds really tough. Um, yeah, hopefully, like I would expect that your online MMIs would be still like a conversation, and there'd be an interviewer um there who would be responding to you, but it might just be on Zoom or something like that. I would Imperial does pre-recorded for first stage. Hmm, okay, that's really interesting. I'd have a I'd have to have a look at that a little bit more depth. I'm sorry, I've not seen pre-recorded MMIs before, but that sounds pretty brutal in all honesty. I would say approach it the same way you would approach an MMI with someone there, but recognize that you might have to then speak for the full time that you need to pre-record the video for. So if you're recording for a 5 minute video or something like that, you expect that you're going to have to speak for the 5 minutes, but follow the same structure as you're following for anything else. Talk out loud, show depth, except that you might get the question wrong because that's fine, and maybe they won't judge as hardly on that. Because again, there won't be someone to show you the way if you're going on the wrong direction. But again, talking out loud and pretending there's someone there is probably the most helpful thing. But that is a mean question. Should your conclusion on Doctor Strikes, for example, be on balance that you're against or for it? Yeah, probably a little bit more nuanced than that. Recognizing when, the Doctor Strike's really important and recognizing that um or recognizing when Doctor Strikes are particularly useful, and recognizing when they can be a detriment to patients, recognizing what the risks are. Yeah, but yes, overall go for that. Should we make our own contrasting questions in a pre-recorded MMI? Then no, don't do that. Don't like ask yourself a question that's different from the question that you've given. That'll throw you off more. I think try and basically plan as much depth as you can for the questions that you are given. I would be the only way I would think about doing it. I wouldn't plan follow-up questions because you don't know what their follow-up questions would have been. So you can't preempt a follow-up question if you don't know what that would look like. So I wouldn't do that. But again, very mean type of MMI circuit. That would be that I don't know if I would be successful in a pre-recorded MMI where there was no one sitting in front of me, like at least giving me some feedback from body language or something like that. But and then the last one is role play. So here, the opposite of, I guess, a pre-recorded MMI, where you actually have to go and talk to an actor. The most common types are usually breaking bad news, non-clinical. Um, so you won't be asked like break bad news and then give information about a patient's chemotherapy or something like that. It will be break bad news that you've lost your friend's dog. It'll be a non-clinical breaking bad news or giving some sort of information to someone or asking things. I remember Bristol 6 years ago, was a you just were given a patient with depression and asked to just chat with them for 5, 10 minutes, and they were just really gauging your body language, how you would talk to someone, and how you would get information from someone. So they were more gauging your questions rather than how you would respond to them. Um, the only thing I would learn for this is spikes as the approach to breaking bad news. So setting, perception, invitation, knowledge, emotion, strategy. You probably don't need to do knowledge giving there, and you probably don't need to do strategy, but setting, so just like asking the patient if it's okay, if they're comfortable where they are, if they want anyone in the room with them, those kind of things. Perception, asking them what they're expecting from today. Invitation, so saying, I've got some news for you. Unfortunately, it's not what we wanted. And that's really important. It's called a warning shot. So when you're doing breaking bad news, you want to give a warning shot. So you want to say, unfortunately, it's not what we expected, and then pause, and then say, I've lost your dog. Um, and that would be like a good way of doing it. And then after that, you then do like knowledge and emotion, but you're not going to be expected really to do knowledge that much. You're just kind of gauging the emotion and like responding appropriately to emotions and stuff. Um, okay, two questions here. I got, are there some critical questions that could be utilized in the context of answering other questions that you would? I'm not exactly sure what that question means. So sorry. If a patient is getting worked up about the situation and starts insulting you and stands up, what do? You just let them do that. Like it's not you going wrong, it's the actor really wanting to test your ability. If you respond with their heavy emotion to their heavy emotion with heavy emotion, you're not having a productive dialogue or conversation. Usually the actors, if they're going to get angry and they're going to be like raging, they'll calm themselves down. But be calm, be relaxed, and just let them talk. Um, because you can't do anything there. Don't ask them to sit down or anything like that. Just be like, I understand that this is quite difficult for you. I'm sorry that this is the news. This isn't what we hoped for. Um, or something like that. But try and let the person kind of work themselves out. I always find myself accidentally laughing due to the awkward nature of the scenario and knowing it's an actor. How do I stop doing this? I used to be the same. Don't worry. You kind of work out of it. You have to like hold it in. You have to really hold it in. What I would do is briefly, again, this isn't appropriate to do all the time, but if you find yourself kind of getting to a point where you might start laughing, divert your eye away, like not look away, but stop making eye contact with the actor. Because that then kind of then just makes them a voice, and then you're not responding as directly. And then make eye contact again when you've kind of composed yourself a little bit. That's kind of how I still do that in Oskies. I agree though. I used to be the same. Don't worry. Probably still am. Um, so that's completely normal. Okay, so we're going to quickly run through the last bits. Core communication, which I talked about in the last session as well. But remember to introduce yourself. Always remember to introduce yourself. Just say, "Hi, my name's Hamza. Thank you for interviewing me." Or, "Hi, my name's Hamza. I'm happy to answer this question," or "Thanks for the question." It just breaks the ice. And then remember, you have to really lock in on talking really, really slowly, about 30 to 50% slower on the day, because mentally you're gonna end up talking too fast, and then the interview is gonna be like it's gonna be a much quicker and probably less efficient. Would I ever shake the interviewer's hand? No. Maybe in an Oxbridge panel, probably the only time I would consider doing it. Um, not definitely not in an MMI though. I just don't think there's ever an appropriate time to shake the interviewer's hand in an MMI. I just don't think you have the time to do it. In a panel, maybe if you're in a like a in an Oxbridge panel, the reason is because you're often inside rooms where you're not in a giant hall with loads of people. Maybe that might happen, but again, it's unlikely. I just wouldn't take the chance. What should you ask if they ask if you have any questions? Ask questions about the university, ask questions about the experience. I mean, there's only a couple of interviews I know do that. Um, so most interviews, there's a student portion of the interview that normally happens after or before the interview where you have an opportunity to speak to current students. But most of the interview is obviously interviewer led, and you won't have an opportunity to ask questions. If they do ask you if you have any questions, ask questions you might have about the university. Just say, "Oh, so I know you do this style of teaching. Tell me a bit more about how that works on a day to day. Or what would an average week look like if I come to this university?" Show an interest. Remember, you're applying to go there for at least 6 years of your life. Ask questions about the experience of being there for at least 6 years. I mean, like, be curious. If you don't have any questions, say, no, I'm okay. I don't really have any questions at the moment. Do you know how Gateway Foundation year interviews differ from first year entry? Sadly, could not tell you. And I guess it depends on the interview and the university. Like they'll be highly dependent on the universities themselves. Common things are common. Ethics will be in there. Skills, work experience, all of those style of things will be there. But there probably isn't a significant amount of difference. Do you have time to introduce yourself at a role play station? Of course you do. Yeah. So at the beginning of the role play station, you definitely should introduce yourself. Um, so like you should be like, "Hi, my name's Hamza. Thank you. Hi, my name's Hamza. It's nice to meet you." Like that would be how you introduce a conversation, right? So yes, in a role play, you definitely need to be introducing yourself. Yeah. I was told to not ask questions that you can find out on the web. I disagree with that. I think curiosity, I think the best, like there's information on the web that you definitely want to know. Um, you definitely want to know from someone who's experiencing it. So if it's a student-led station or if it's an interviewer station and you want to find out something, ask. How formally you expect it to dress? I'd go in a suit. That's what I did for every one of my interviews. A blazer. I know most people came in their school uniform. I know a lot of people don't have school uniforms at sixth form, but like, formal attire, which is what they would wear to school, that's probably appropriate. What about for group interviews? So group interviews, the big thing they're looking for is how well you work in a team. So remember, be active listening, your standard team working skills, active listening, direct communication. Make sure you don't fade into the background. Be direct with what you're saying, and like be clear with what you're looking to get out of it. Right. Yeah, so key takeaways, how the MMI is structured, what the different stations normally are. So we've talked about that over the two sessions. High scoring strategies, we've talked about how to work on those things, mastering the necessary skills. Essentially, an interview, they already like you. This was the big advice I got told before I went to my first interview. It was by looking at your application, they kind of already like you because they're inviting you to interview. Interviews are really time consuming and expensive processes for universities. They don't want to interview someone they don't already think would be a good enough candidate to come to their medical school. All you need to do is prove that. So go into the interview and prove yourself to be a good enough candidate. Be confident, be direct, show that you've got the skills, show you've got the insight, show you've got the knowledge. That's all you need to do. And then, yeah, resetting between stations, kind of core communication stuff, which we've talked about.
Great, thank you so much. And thank you so much, everyone. I think we are not going to be having enough time to answer the questions now, as I know Hamza's been answering a lot of questions throughout the webinar as well. What I've just done is I've just sent a recording of the previous webinar as well. So yeah, thank you so much to everyone for attending. Just on the screen, there is a little QR code which you can just give us some feedback on this webinar. We do a lot of webinars, as I'm sure you know, and it's great to understand what we can do better and how we can improve as well. So that would be amazing. Or if you just want to say thank you and let us know how it went, that would be great. But yeah, thank you so much, Hamza, for your time. And thank you everybody for attending as well. It's been a really great turnout and it was wonderful to see you all. Look forward to receiving the email tomorrow with the recording and all the other information in. And if you need anything from Medic Mind, please just feel free to send us a contact form or anything else.